righty. Thank you everyone for joining the Barcliff Group's Fireside Chat with Dr. Ozzie Ahmed. I would say he's a guest, but he's no longer a guest. He's family now. He's been on our Fireside Chats with us at least 3 times, and we're coming back this opportunity to talk about the COVID-19 vaccination. And I apologize, I haven't even introduced myself. I was so excited to get on this topic. But my name is Sharonica Barcliff. I'm the CEO and founder of the Barcliff Group Incorporated. And part of one of our philanthropic efforts is to hold fireside chats as a platform for education for the community, but also providing a authentic and organic dialogue. We always encourage the community to do their own research, but we want to create a place for transparency as we talk about various topics in healthcare. So with that being said, we will hop right on in with Dr. Ahmed, medical doctor and epidemiologist. So I'll set the stage, Dr. Ahmed. I have the pleasure of hearing thoughts from the community and thoughts from the healthcare community. And it's been a lot of rumble about this COVID-19 vaccination, particularly with Pfizer leading those efforts and launching the administration of the vaccine next year. But I want to take a step back because when I have these 2 ears in these 2 different spheres, one of the questions that I hear from the community is, what exactly is this vaccine? They've said that it doesn't contain the virus, so there's a little bit of information that could be shared. So tell us about the vaccine and how it was developed.
Well, first I want to thank you, Veronica, for bringing me to this discussion and hosting this today. And I would like to echo everything you're saying in terms of science and being a sort of educational program.
Thank you.
I would like to first say vaccination started a very long time ago. And first we started with a lot of the live attenuated or the kind of living but weakened type of vaccines. And then we ended up recently getting into the, in addition to killed vaccines. And then we ended up getting into these new platforms recently. The first platform is messenger RNA. And then there's something called vector vaccines. Mm-hmm. So in the old days, when we used to develop either the live attenuated, like the measles, mumps, rubella, MMR, that kids take, these things took years and years in development because the nature of it is first you get the viruses and then you grow them up in mostly eggs. And you needed like millions and millions of eggs. I heard a number in England that they used to have 38 million eggs daily.
Wow.
Just to propagate the virus in order to get enough virus and then take it and then build on it or kill it or weaken by something. Wow. And I think these days with these new platforms, there is no need for a long period of time to grow the virus. So that's part one. So that's why these new platforms ended up being more kind of rapid development. Not because somebody pushed them politically, because the platform was there.
Right.
And they used it before they started on Zika and it never saw the light because kind of Zika, now it's not an endemic disease like it used to be. So things sometimes start and stop, but the platform is still there. Okay. So this new platform is, like I said in the beginning, a messenger RNA. Messenger RNA, by definition, is some molecules, some particles that takes orders from the nucleus, from the DNA, and then flip it into a kind of a useful orders to the cell to make certain amount of proteins. And who carries this message is the messenger RNA from the nucleus. Okay. So it goes inside the cell and then it starts creating different types of proteins. That's how the cell functions.
So it's reproducing, if you will.
Right. So what happens is since this epidemic started, about 2 weeks or 3 weeks in China, they produced and published the genetic code, like immediately after the virus was kind of discovered. So everybody in the world have had access to this genetic code, which means that this wasn't available to us like 10 years, 15 years, 20 years ago. So when people have this access, they can then reconstitute parts of the genetics of the virus and then in the lab, and then as a result kind of introduce it in the body if they want to. So with this genetic code being produced, every company that, for example, Moderna is the company in Massachusetts, and then Pfizer through BioNTech, which is their partner in Germany, they ended up having a head start to really think about what would be the best way to use some of these genetic code. And they found the best way is this spike protein. What is this protein? Protein is on the surface of the virus, the coronavirus, are the ones that they ended up attaching the virus to the cell. So if you impair this process or you do something to this process, the virus will not enter in the cell. So they got the genetic code that's responsible to make this spike protein. And they have that with a biochemically made messenger RNA in the lab. And they inject this. If you inject it without a lot of things to stabilize it, it kind of deteriorates in your body faster. And this, we'll get into this point a minute after that. But the messenger RNA is a way to bypass everything in the cell and orders some part of our cells called the ribosome, which is like the machine that makes proteins, to make a similar protein looking like the spike protein. So what happens after that? So you have now a vehicle introduced into the cell to tell the cell, make these type of proteins. So they make the proteins that the body feels that it may be the virus. The body doesn't know it is not the virus. So it starts creating or making antibodies and T cells and all the kind of immune reaction that results in people having these fighting cells sitting there in the body. So now say that you are exposed to the real virus. Once the virus gets in, they start making these spike proteins to latch onto the cells. So now the body recognizes it with these antibodies and neutralize it. And then you're going to get the infection. So that's how it works.
Quick segue question, because I know this has come up a lot and you touched on it a little bit in your response. And it is the concern about the fast-paced production of this vaccine. And you spoke about how they have the genetic code or the information to work from this. And the industry says it takes at least 3 to 4 years to produce a vaccine. What impact, if any, at this point with administering the COVID-19 vaccine? Will we see any backlash or something that we should be concerned about in terms of it being very new? I know we've come a very long way in science and with the amount of information that's available, but are there anything that we need to be concerned about in terms of it being produced in less than a year and testing with the community?
Okay, I think we need to distinguish between being done in an expedient fashion because of availability of these platforms, these kind of new innovative ways to make vaccines, or being expedited just for political expediency.
That's a very good point.
And I think that's you know, people need to see and understand that available platforms to make vaccines these days are different than old days. So the second thing that happened during the making of this vaccine, if you will, is in the past we used to have several phases, several stages for the vaccine. So you have phase one, which just makes sure the compound doesn't kill people and is safe to use, and doesn't have severe side effects or reactions. And then is you wait for this phase one and you go phase two. So this phase one can take months, maybe a year, to make sure that everything is okay. And then after that, you go to phase two. And phase two is not the safety, but the efficacy part, like how good it is in producing antibodies, for example. And this thing can take a few years sometimes, phase two. And then you go phase three, which is really looking at both efficacy and safety together in a larger number of people. But in addition, they also give some people placebo and some people the shot, and then see the effects, side effects in the two groups. Right. So you would say to yourself, okay, if the placebo caused 5% headaches and the shot have 5% headaches, then really the side effects are comparable. But if you say one of them is like, sometimes actually the virus, the study group ended up having less side effects. So you know that definitely the whatever you're testing is okay. The vaccine is okay. So that's the third stage. Now with these new platforms, you can overlap them. So you ended up like phase 1/2. So they go from phase to phase in a faster way, and then they have them parallel to each other. Like you can have a group going through phase A, and then another group going, or phase one, another group going to the phase two. So you have a head start on phase two. You don't wait till phase one to end and you start phase two. So this overlapping phases ended up cutting a lot of time of regular clinical trials. So it was like something new, and I think it will impact even future vaccine developments, because now they know that they can do stuff with these phases, right? Rather than wait. And the other thing we have also to know that when you are trying to get really a good handle on everything that goes with the vaccines, you need to have a certain number of people going to be vaccinated, a number of people being the control group, and. So these numbers being sometimes in the tens of thousands or hundreds of thousands, really the more the sample size, the better sometimes. But also it dictates a lot of other factors in the experiment, like, alpha error, beta error, different things that you need to make sure your findings are not due to chance, but it's due to whatever you are studying. So all these variables sometimes can delay production of the vaccines, because you need to have the right number of people, the right characteristics of people. You're looking for representation from all groups, African Americans, white, and especially if you're using the world as your market. So you now want to have all racial groups, or all sex groups, or all ages. So you want everything represented, so you can generalize your findings. So the more you have a representative sample, which they did a good job in this study, in this kind of vaccine production trial, they really did a pretty good representation, all types in it. Obviously, you wouldn't have the same number of African Americans like, Caucasians in the study, just because of the distribution to begin with. But they have representation. And actually, some of the findings are very interesting, because it's like they found in African Americans the efficacy sometimes can get to like 100% more than Caucasians, which is a little bit close to 95. So, really, I think what I'm trying to say here is the overlapping phases, the inclusion of all representative groups makes me more comfortable that these findings are not like premature or due to chance or anything else you would say as something bad. But I think what's against it is this level of trust that we know that in the community out there. And, that's a little bit a harder thing to overcome, but that's, I think, the role of this educational sessions.
Yes, yes. And since we'll actually touch on that right now, since you brought it up, Dr. Ahmed, is this distrust. And we had prefaced before in our pre-production about the Tuskegee trials of 1932. And for those who don't know, we encourage you to research. The Tuskegee trials were of 600 Black sharecroppers. They were promised free health care to cure black blood or syphilis at the time. It ended up that they were given placebos so that they could study the natural occurrence of syphilis, despite finding a solution of penicillin in 1947. And it was just exposed in 1972. So I give this background because this history, in addition to our current social and racial injustice that we're experiencing here in the United States and in the world, definitely is a valid stance to have when considering taking this vaccination. So Dr. Ahmed, what are your thoughts on that? And do you think that mind frame or those feelings are valid or irrational?
Well, I think they are founded in reality, because these fears are really natural. So, however, two things really we need to be thinking about. One thing is what do you call the protection of the whole public rather than certain segments of the public. And I know that the administration of the vaccine is going after certain segments that are at a higher risk first, but the idea is to get to everybody, right? So the number that came up in the literature a lot about the herd protection, I don't want to use herd immunity very much, herd protection. The herd protection situation is about 70 to maybe 80% of people should have this vaccination to get to this point. So if we have a lot of no takers, we are going to be in the same place we're in today in another 5 years, which I don't think people, when they realize that, they would like to continue to live in isolation or under quarantine or lockdowns sometimes, or whatever you call them, every now and then, and you know, continue to wear masks for 5 years. It's not comfortable. So I believe that people should really understand that all of us have a role in this. It's not just for the high-risk groups. And also the other thing that's really important is African Americans die at very high levels from this, and they get hospitalized from this too at a much, much higher rate. So the rates that are mentioned in the CDC even publications, that they are about 4 times more likely to be admitted, 3 times to die compared to white people. So you have a vaccine against a killer. That's number one. You have a vaccine that has shown efficacy in similar people with the same racial, genetic makeup. If there is one like a little bit different, if you will, if you think, despite the fact that we know that from human genome, it's everybody is similar to everybody when it gets to really genetics. It's like 99.99. And then there's a difference in these 0.01% genes. So from susceptibility and lack of it, the African American people seem to get disease more severe and end up dying, whether for some structural issues and lack of access and whatever, or whether it's something related to more
Right.
susceptibility? We don't know very much
Mm-hmm.
about that part. So I encourage everybody to take it. And the other point that I heard from other people, other than the history of Tuskegee and stuff, that
Mm-hmm.
the involvement of Bill Gates and you put chips into you
Yes.
and
Mm-hmm.
all this kind of stuff. Uh, I think this point that you made a few minutes ago about the nanoparticles is the messenger RNA when they produce it. If you give a shot of it to somebody,
Mm-hmm.
the body degrades it, kills it, like
Right.
our own cells would degrade it. So it wouldn't produce antibodies. So what they did, if they had a molecule made in the lab of fat, so it's a fat-like globule, a fat particle.
Mm-hmm.
So it's lipids. So they call it lipid nanoparticles. And these lipids in an envelope that's made of these nanoparticles encircles the messenger RNA. So when you inject it, it's going to take a longer time for the body to dissolve this and go into the messenger RNA. So what happens is like a carrier that gets it through, and as a result, it lasts longer and doesn't get biodegraded, and it ended up going into the machinery of the cell, or hijack it or order it to make these spike proteins. So it has time, because
Okay.
after that, it's going to go away. Like just the thing is done,
Mm-hmm.
and it's going to be biodegradable. It's going to disappear. So the nanoparticle component is really like intriguing because a lot of people think, oh, the government is putting things into this lipid nanoparticle molecule. Well, it's manufactured by a drug company. I don't think this drug company gives it to the whole world. It's not like only to Americans. Same exact vaccine. So the second part of this is the fact that in addition to these nanoparticles and the lipids that are involved in making the vaccine, that we know in a lot of times that when people have something new, they ended up thinking that with the newness, there might be something, I don't know, mysterious about it. And I think we're here to dispel this myth that, a few days ago, I have a friend of mine who is a physician who's calling me about the same thing, about these mysterious microchips.
Yes.
And well educated, reads everything, and is still suspicious.
Mm-hmm.
So, yeah, there is maybe some people misunderstood. There is an RFID thing that goes, it's a radio frequency chip that's attached to the syringe, not inside the syringe. And the reason for it is they want to know where it was distributed and when it was given. So it sends kind of information to collect information about the time of using the syringe, but it is not in the solution. It's outside. It's on the outside. That doesn't affect anything.
And I think that a lot of anxiety and concern comes from that because they're like, okay, so they're collecting this information. How will it be used? Would it be used to our benefit, to our detriment? And it's interesting because we're combating a pandemic and in the midst of having these legitimate concerns. So I'm glad that you walked through this chip that is not in the vaccine is to record information about administration. What are your thoughts on that? You've been expounding already, but thank you for going into detail, because a lot of folks that I'm hearing are like, well, you know what, it's like the Apple iPhone. You know? And I say that, hi Apple, this is not and I want a shameless plug. We are not paid to advocate or to market for any brand or opportunity. We're just having dialogue. But I've heard communities like, well, we'll wait till a year because when a new Apple iPhone releases, there are always glitches. So they said, we'll wait a year until, they kind of fix up anything that could be a glitch, if you will, air glitch. What are your thoughts on that and the curve in terms of epidemiology in this pandemic? what does the delay of taking a vaccine, how would that impact bettering our world and our nation?
I think, I mean, I'm glad you raised this point because, again, it goes to the fact that we need to have a speedy process to increase people's protection against the virus. And it's everything we do is a risk-benefit analysis. So if the risks are more than the benefits, then the intervention is not that good. If the benefits outweigh the risks, then there's nothing we know about that's done without risks. Every pill we take, every breath we take, walking the street, there's risk. Like you're walking, you don't know what's in the environment. Could be something in the air. You're gonna stop breathing if you are afraid of whatever people are putting in the air. So we need to be realistic about the amount of risk and the amount of benefit. And I think here the benefit outweighs the risk. Why? The disease is fatal in about maybe 1 to 3% of people that get the disease. A lot of people end up with severe cases and go to the hospital and stay in ICU, young or old. And sometimes we don't know why. Like why 30 some years old die out of it. We don't know why. And the third thing is it doesn't really distinguish between healthy, sick, old, young. So the disease is very, it's a very severe and it's a very unpredictable course of this disease. So all these things favor the fact that we should get something to protect us against these diseases. And this was the reason for, we know that in the early 1900s, we didn't have a shot for measles or mumps or anything. And people, ended up giving it intentionally to their kids. Sometimes we used to have these measles parties, they call them, and they just mix the kids intentionally to get them to get the measles. Right, to get the immunity from the infection because we didn't have anything. I don't think that that's reasonable for COVID because of the impact. And then if we delay, waiting for more results, we are probably, the direction we're going at least in the United States, is maybe 50,000 deaths every month. So at what cost the wait is? So are we gonna wait till we have like 200 people getting infected, 200 million people get infected, and we are gonna wait until 600,000 a year dying and continue to die in order to get be comfortable? So I think time is a factor.
Yeah.
Because this disease, again, the R node, which is reproduction time or reproduction number. So this reproduction number measures how infectious the disease is. It's like for flu is 0.8 or 1%. 1% infect less than 1. For this disease is about 2.8 or 2.7. So each one infects 3 without social distancing, without masks, without anything. If we just leave people normally. So when you have a disease that's severe, that's fatal, that gets you to the hospital, that all this kind of stuff, and it's a very infectious disease, you don't take chances with. But then, but the same notion is if you get that vaccine, you just don't sort of assume that you are 100% protected. You still need to use a mask. You still need to, for a while, until maybe there will be more protection for a lot of people, like I started the conversation earlier, without having a lot of people protected.
Right.
This thing will continue, the hygienic things, the population inconvenience, I guess.
Yeah. And I will also segue with that because with the level setting the expectation, right?
So we've covered how it's developed, how it's administered. We've covered mistrust historically. And now we're here with our dialogue in terms of empirical fact, study, new advances, innovation. So in level setting this entire conversation, let's talk about side effects so that when someone gets the vaccination, oh, I was supposed to be cured. What is this? See, I knew it. I knew it. What are these side effects that are associated with this vaccination?
So the side effects are really mild, I would say. They last for close to 2 days max, sometimes few hours, and mostly like any vaccine. So when people get the flu vaccine, they get local site like of injection reactions, like your arm gets a little bit like sore. You might touch it and it feels hot, the same area you got the shot in. And I'm not saying everybody gets this, but some. And you might feel that you are a little bit tired, so you get fatigue, you get myalgia, muscle aches, and pains. And then some people get headaches. So generally, the side effects are transient, and the side effects are not severe.
Okay.
So I would say very comparable to other vaccines. And I don't believe that it's like a deterrent from taking this particular vaccine. It's, I think, because of newness, people are scared.
It was just published. I was watching the news and I'm just trying to stay up on trending topics. And they were saying that 2 folks in the UK had anaphylactic shock due to being hyperallergic. What does this mean in terms of for those who have been noted to be hyperallergic and for those who are immunocompromised in terms of side effects?
For people that are immunocompromised, I don't think it's an issue. Why? Because I think in the sampling that they have people with chronic conditions, with immunocompromised, with all this kind of stuff. So because it's not a virus, it's not a live virus, it's not a weakened virus, it doesn't have any viral product. So immunocompromised is okay, I would say. But the point you first made about this, I think there were a couple of nurses in England that they get this severe reaction to it. I think that's probably a possibility that we need to be thinking about among our population here. And when people are very allergic to a lot of things, meaning, there are people that they're allergic to peanuts and they're allergic to, different like latex and, a lot of things that other people are not allergic to. We don't know if they'll be allergic to this nanoparticles or the constituents of this or not, because it's not something that was done before.
Okay.
So I would advise, or I would say that from what we learned from the British kind of experience is, if you remember also these 2 nurses has EpiPen on them.
Yes.
It means that they are really bad, like severe. Like they use the EpiPen not because of the shot, they use it routinely when something bad happens and they feel they're not breathing right. So for people with severe allergies, I think from this experiment in England, they need to be carrying this EpiPen or something similar, and just think about it as another episode or another thing of like a severe reaction like they got before from something else, and they just use it after they get the shot rather than not getting vaccinated. That will be my own feeling.
And that's a good point, because we do want to educate in terms of, you're hyperallergic, you do have an EpiPen, it will be a good care conscious decision when you get the vaccination to have that by your side, just in case.
Exactly.
Have that out there. And we do have a question in terms of when you get the vaccination, when you test positive, and we pretty much covered this, but just to answer that in prudent layperson terms, when you get the vaccination, will the individual test positive?
That's a very good question. I think from the spike protein standpoint, if you immediately after you get the infection, um, I would say biochemically, you should be testing positive because you
Okay.
have part of the virus in your body,
Hmm.
right?
Right.
Um, However, it's a good question, but I really don't know if that current testing tests for the spike protein or
Okay.
tests for any other viral particle.
Okay.
So I need to research this and maybe get you an answer later, but I don't really top of my head.
Yeah. And the great thing about this, and what I love about our conversations and our dialogue, Dr. Ahmed, is that no one has all the answers. We are in current pursuit to get such. So when we're speaking, we're speaking as much as we know right now, and we're sharing that information. So I just thank you for, again, your expertise, your dialogue, your empathy towards current events in terms of everything that's going on. And I want to offer you the platform to speak to anything else that we may not have touched on. Any parting words for our viewers today?
I think what I'm looking forward to is especially the most vulnerable groups. When I say vulnerable, there are obviously the healthcare workers, which will be like the most exposed, I would say.
Your front
And
line.
then, yeah, and they see everybody and they are like really the army out there fighting.
Yes.
And followed by elderly and sick people, they are very vulnerable as well.
Yes.
And I think when I think of vulnerability in general, I think about African Americans being
Yes.
um, overrepresented in the numbers, especially of severe cases and fatalities from the virus and deaths due to the virus. So, from my old days working, at Meharry and working with the African American populations, I think they are at a disadvantage always in terms of disparities to access, disparities to treatment, disparities this one for the disease itself that attacks them in a much higher rates. So when you are at a disadvantage to begin with, I think trusting currently, despite the fact that it's in short supply, is a good thing to have to overcome some of these disparities rather than you put yourself in a more disadvantage. So if you are prone to something like um, if you are prone to a certain disease, you have to really make sure this disease uh, is very hard to catch up with you. So I would just encourage everybody to try to think about the current situation rather than the past,
Mhm.
because the past is a past, and despite the fact that we should learn from it, we are sure that this kind of treatment is not offering, for example, African Americans a different kind of vaccine. So we're giving the same thing to everybody.
Mhm.
So in my old days, we used to read about these disparities that happened maybe in the 80s and 70s. And I went and testified on the behalf of my colleagues and my research that I was doing in Healthy People 2000, which seems to be a long time ago now. But the same exact problems that we experienced with the African American populations are the same exact problems that we're experiencing today. There's no change. Like, there are systematic, structural issues in healthcare,
Yes.
among other things, and social determinants of health that ended up unfavorably affecting this particular population. And as a result, I would say for Hispanics, for Blacks, for all minorities, everybody should be really sort of adopting the same behaviors like most of our white Caucasian people acceptance and everything else, and don't think too much about, the very unpleasant past at the current point, because that can keep you behind. And as a result of you being behind, people tend to sometimes congregate and talk to and uh, with other people, like-minded people that they are in their community. So what happens is this thought process will permeate through the community, will be everybody is thinking the same way, is mistrusting.
Yeah.
And when we are more mistrusting, I believe that we'll be at a more disadvantage. And the disease doesn't wait really to take permission from anybody to attack us. Add to this the systematic structural lack of access. Maybe sometimes they don't take people seriously in the emergency rooms, or when they put them in the hospital, maybe they wait longer to get them treatment. We know these things happening.
Yeah.
But then don't also wait. Don't also say to yourself, I'm okay, I want to wait. I want to wait another year. I want to wait 2 years. Because there's no assurances within these 2 years something not good could happen to you. I don't want to say something bad, said something not as good,
Right. Rephrase that. Thank you, Dr. Ahmed, because for the Black and Brown community, that is a lot to digest and to consider. And I'm hoping that this spurs more dialogue and a paradigm shift in terms of this. And I want to extend to our viewers, I know when viewing this this production, you may have questions. And I know a lot of times those questions may be felt they aren't welcomed, but they are here. So if you have a question that you'd like Dr. Ahmed and myself to address in our next recording, please send them. You can drop them below our YouTube, or you can actually email info@thebarcliffgroup.com your private question, and we will keep who you are anonymous, and we'll address the question in our next recording. But I did want to extend that opportunity because, again, this is one of the community-based education avenues of the Barcliff Group. We want to certainly provide that level of transparency and vulnerability to get your questions heard and your perspective said. So I just want to end with that. Again, thanking you, Dr. Ahmed, for our dialogue today. There'll be many, many more. So he's a whole rock star. And I just want to wish everyone well, wish everyone and their families well, and to go be great. So thank you.
Thank you.